Thank you for watching KTN. Welcome back. This is Health and Wellness. We continue the conversations around maternal health, maternal death, newborn health, and newborn death. We're canvassing everything in here. And we come to you, Dr. Menge.
Yes.
Dr. When we look at an expectant mother, right? An expectant mother, let's put it like that.
Yes.
And one asks the question, what are some of the danger signs that we need to look at? Because especially for new parents, we don't know. We've not been parents before.
True.
You know, we've not been parents before, so we don't know what are the danger signs. We don't know what to look at. I'm going to tell you out of experience, because I remember there is a time someone I know felt some pain and assumed, it's just pain. Before you know it, they started sporting, and that's how they lost the baby. You know, so in terms of the new, not the new danger signs that are there during pregnancy, at labor, and after delivery, what should we be looking at?
Thank you. And that's a very pregnant question, to use the same terminology.
Pregnant, eh?
Yes. So oftentimes we assume that we start to go to the clinic when one is already pregnant. Unfortunately, the best time to start clinic is before the pregnancy happens.
When you're trying out?
Even before you start trying.
Yes.
Now you've thought about it. If you're using a family planning or contraception, you've decided, as a couple, you want to remove this contraceptive method to try and see if you can get pregnant. Before it is removed, see your gynecologist or see the doctor nearby. And the reason is that we need a body that is well endowed and ready to carry a pregnancy. And sometimes from past pregnancy experiences, there are conditions that can be recurrent. They can happen again and again, such as high blood pressure, for example. And so high sugar problems, such as diabetes. And so it is important that the woman is assessed by a doctor. And we are certain that she's in good health to carry the pregnancy before the pregnancy happens. We call it preconception care. Of course, that's the time also if we are to give additive nutrients such as building blood level, it is the best time to start it off. So a pregnancy happens and we notice we are expectant by missing monthly period, and then probably you do a home test and yes, there are 2 lines and everybody is happy. Or for those who didn't plan, probably a bit of a regret. But anyway, there's a life that is coming forth. As soon as one knows they're pregnant, they need to start their clinic. So the first time to go to the clinic is as soon as we know we are pregnant, hopefully within the first 3 months of pregnancy. And in this period of pregnancy, the things we consider concerning, if the woman experiences bleeding vaginally, don't wait for it to be torrential. That's spotting.
Doc, please make it simple. Torrential.
Yes. Torrential means a lot.
Okay. Heavy.
Feeling up, heavy bleeding. Don't wait for it to be heavy bleeding. Okay? And that spotting should take you to the hospital. Pain in the lower abdomen should make you go to the hospital. If you're passing urine and there's pain while passing urine, you're passing urine many times more than usual, seek care. Now, sometimes in the early phase of pregnancy, there's vomiting, you're unable to retain food, you're trying to eat food and everything is coming out. Even water can't get in. You see some food and the smell throws you away. Sometimes we need to be seen just to be able to be sure.
Doc, those things are not normal? Because you're told,
yes.
Feeling nauseated is normal. When I see water, at times, even when you see your partner.
Totally in agreement. However, if you're at a place where you can't even retain water, when you take a bite of food, it's coming out. You're feeling weak. You're feeling light in the body. So the little nausea, vomiting once or twice in a day, but you're able to drink water, you can drink some liquid food, you can actually eat and the food remains in the tummy, considered normal. Now, before you assume it is normal, I would rather be checked and be told, all right, this seems not too bad, we can continue monitoring you from home without assuming. So that is first trimester, first 3 months. In the second trimester, of course, pregnancy, we divide it into 3 segments. So one segment, we call it a trimester. So trimester 1, trimester 2, trimester 3. In the second trimester is where changes in the body are becoming obvious. Some weight gain is happening. At some stage, there'll be the baby moving. You'll feel some little kicks. And that's a very fundamental stage of pregnancy. So that in this period as well, if the baby movement has started happening, and then suddenly that movement is not present, you're no longer feeling the baby playing inside the womb, or is significantly reduced, don't wait. Don't even sleep in the house. Go to the hospital. Bleeding through the vagina is also not normal, even in this pregnancy, in this stage of pregnancy. The baby is surrounded by a beautiful fluid. We call it amniotic fluid. It is covered, wrapped up in very beautiful clothing. If that clothing breaks and there's a gush of water coming out vaginally to the ground or along the leg until the floor, or where you are sleeping, the place is wet and you're wondering, is this urine? Urine has a very specific smell. Please go to the hospital, okay? Pains in the lower abdomen, go to the hospital. If it's a pain that is going, coming back, and this pain is becoming stronger as time progresses, we need to go to the hospital. Furthermore, any ill health, whether it is high temperature, you're feeling like you have malaria. Some people describe it as feeling like I have a malaria. So high temperature in the body, please go to the hospital. Vomiting, everything. Then there's a third trimester where it's again very critical. That again, bleeding vaginally, the water breaking that I've described, the pains, the lower tummy going to the back, fainting, high temperature in the body. And if you have a family around you, if they notice that you are losing awareness, either you fell and you're behaving as if you have epilepsy, in our language we call it convulsion or seizures, be taken to the hospital immediately. And of course, during the clinic period, there's something we call blood pressure that is monitored every time you go to the clinic. This blood pressure, if you are told this blood pressure is high, please, it needs to be taken care of and not assumed. And this can present with headache that is not going away. Whether you rest, do paracetamol, you take water, the headache is not going away. It's a very severe headache. Don't sit in the house. Come to the hospital. If you have pains in the upper part of the abdomen, so this is the abdomen. I know we use it as stomach sometimes, but the upper part of the stomach for the common language, or the pain on the right side of the upper part of the abdomen, please go to the hospital. It may just be the early sign that the pressure is high, okay? If you're finding yourself not able to read things clearly because the vision is becoming blurry, the name Amenge is not reading Amenge clearly. You're seeing letters are coming, merging from each other, one to another. Come to the hospital. Now, as I conclude this part, of course, I'm going to come after the delivery, that at each stage, we are going to the clinic. It's advisable that we do 8 clinic visits. At each of these clinic visits, there are things that needs to be done. And we'll only be able to achieve this goal if we collaborate the person who is pregnant, the woman, her partner, and her society. And of course, the hospital must be available as well. Now, after delivery, excessive bleeding, and sometimes women give birth very well, then they go home, okay, with the baby. Of course, there are things that must make us go back to the hospital. If you have a pad that you are using, and the pad is filling within 1 hour, it's full. Within 2 hours, it is full. You can't sit in the house. That let me monitor this. Because the next time you'll be reaching the hospital, we cannot save you. Now, excessive bleeding, there's what we call the discharge or the lochia. Blood, the minimal bleeding that happens after delivery from being red, becomes brown, becomes yellow at some point before it clears out. in our language we call it lochia. Is it having a bad smell?
Should it?
It should not have a bad smell. If it has a bad smell, go to the hospital. If you have pain in the tummy that is not, it's more than usual, go to the hospital. If you have fever, temperature, you're feeling like you have malaria symptoms, so you are feeling shiverish, you touch your body, the temperature is high, you're feeling hot. If you have a temperature at home, even the one you use it for the baby, just taking your own temperature and you find it is high more than 38.4, let's say 39 degrees Celsius, go to the hospital. If you find that your tummy is swelling, you left the hospital when it is okay, but suddenly it is swelling, is becoming painful. Whether you gave birth vaginally or you gave birth through cesarean delivery, it is important that you go to the hospital. So in summary, any times whether pregnant or after pregnancy and you experience anything that is not normal, don't put yourself at a task of, let me see if this will be normal. Just go to the hospital and let it be a competent facility where you can get the right advice and the right care.
The right care. Hey, Dr. Bajabir.
Yes.
We've just come from Daktari now painting a picture of the alarm bells that should make one think, I need to go to hospital. That is way from pregnancy all the way to after delivery. Now here we are then, the new angel has popped the eye in your hands, right? And with that then, one asks the question, once you get the baby as a parent, what should I see you do? What are some of the common procedures, common steps that a doctor, like a pediatrician would take? And then again, how do we all now take care of that child after the fact? Because from Daktari now, I am handed over to you. It's you now to take me through with this baby all the way till after they're 5 years old.
Thank you very much. The combination of the mother and the baby, what we call a diet, and this is something very important, that for us, even for us pediatricians, how we receive the baby largely depends on how Dr. Amenge and team took care of this baby when they were in the womb. So I'll give an example. Babies that are born too soon, what we call the premature babies, needed to have taken care of before they are born. In what sense? That the mother should have received some kind of medication called steroids, which will help the baby's lungs to mature, because when a baby is born too early, then the lungs have not matured very well. So the antenatal visit is where taking care of the baby actually starts. And it's very important for us to have these discussions and let our families and our communities know that taking care of a baby starts all the way from the antenatal care, quality antenatal care. So we've received this baby. I'm assuming this is a baby that has been born without any complications. And I'll also go to the other babies briefly that unfortunately are not are compromised or are not born too well. So a baby that has been born very well, and this also captures the part of the postnatal care, and why we say the first 48 hours of a baby are very crucial. So some of the things we really need to take care of is the warmth that actually starts from the labor ward or where the baby is born. And these are some of the things that are inculcated in delivery. We maintain the warm chain for baby. The baby has to be born in somewhere that is very warm, not to be exposed to the cold, has to be rubbed because they come out with all these wet fluids, the fluid that Dr. has talked about, the amniotic fluid. The baby has to be looked from head to toe. Yeah, we have to take the fact, to take into measure the fact that this baby was born at how many weeks? Is it a baby that was born too early, where now we start thinking about incubator care, we start thinking about, medications to make the lungs, expand or breathe better, what we call surfactant? Is it a baby that needs ventilation in an ICU setup? Is it a baby that actually needs skin-to-skin care with the mother? Most of the times, these are the things that we actually look at. And the warm chain starts from the delivery in a warm room, rubbing the baby, making sure that the baby is put skin-to-skin with the mother, because this improves the milk flow. It helps connection with the mother in terms of hormonal balances. It reduces the stress of the mother and makes the baby grow better. But what is most important is that the postnatal age is where we really need to take care of the babies. A lot of complications we see when a child grows sometimes are things that should have been captured at postnatal period. If a baby was twitching, or what we call convulsing, or in local language say kushtuka or kutetemeka, this could be something that is affecting the brain. And sometimes, because we do not teach the mothers or the families the danger signs, then they just assume this is a normal baby movement, especially if it's a baby born for the first, or the parents have this baby, the first baby. So then you come and realize later that the baby has a magnitude or multiple issues because of this one thing. They are on anticonvulsants or medications to stop convulsions at a very young age. They're not able to perform properly in school because intellectual disability. They need special care because they get things like cerebral palsy. So when a baby is born, we stabilize the baby. If it's a well baby, then the mother goes home with the baby, stays with the baby and goes home when discharged. When it's a sick baby, if they are really small, we put them in an incubator and we manage them as a premature baby. If it's a sick child that has infections or other things, we give medication and fluids and things like that. But for a baby that has gone home, we need to teach the mothers the danger signs. This would include fevers, baby not breastfeeding very well, a baby that is very irritable, jaundice, which is the yellowness of the eyes or the skin, convulsions or twitching, very cold or very hot. So these are the things that we actually take care of, and we make sure that even the postnatal team, when the mother comes with the baby, these are the things that are actually looked into in postnatal period. Yes.
Dr. Charles, what are some of the healthcare systems weaknesses that you see today, and how can these be addressed, as well as then plugging in the communities in these spaces? Because we find today that there are those communities or even religious institutions where going to hospital is a no-go zone, that those who equally believe because I was born at home and I grew up to be a good person, my child as well would go through that. So then how do we bring these conversations so that communities see the need of taking the women to hospital to access the best quality health service there is, as well as the weaknesses that we see and how we conceal them?
As you've heard, we really need to take care of the baby, the whole continuum of care, before pregnancy, during pregnancy, and after pregnancy. And what they plan, the every woman, every newborn, everywhere initiative does, it's aware of all these moving pieces. And one of the things that we are now championing is that as we roll it out during the Rapid Result Initiative within the counties, that everyone is brought on board. That is, be it the religious bodies, the administrative, the chiefs, the assistant chiefs have a role. At the community level, the CSOs who are working in those communities, and also the community members themselves, they need to be aware about where we are at the moment and why they all need to come together. And when you look at once a maternal or a newborn death happens, usually a team convenes within the facility, and that's what my colleagues talked about the MPDSR, maternal perinatal death responses, the surveillance bit, and they really look at what really went wrong for us to have this death. They start interrogating from the antenatal attendants, looking at the antenatal booklet, looking at the care during the facilities, during the facility, during delivery, and at the end of it, make a conclusion, was this death preventable or not? If it was preventable, what could we have done? And then they put in measures to prevent any other death from happening. And at the moment, the government has increased that surveillance so that the notifications are not only happening from the community level, but also from the facility level, so that you are able to account for every newborn and every mom who passes away. And when you look at these audits that are being done, the problem are systematic. And we find problems in terms of human resource, not having adequate healthcare providers, at times not having the right medication within the facility that could have saved that mother, or is it blood which is not available? At times when we look at the infrastructure, the mom needed maybe a cesarean section, but it was not available. At times it's the ambulances that needed to be there to transport this mom or baby from one facility to another. And when we look at all this, during this period that we are doing the Rapid Results Initiative, all the partners who are working within health and also beyond health, as we discussed earlier, nutrition plays a part, transport plays a part, communication plays a part. So we need to all come together and really discuss on and make that decision that we want to save our mothers and newborns, have more investments coming in, be it from philanthropies, because as you know, resources are not always adequate. But if we can all mobilize and really decide, for me I think it's a decision, as Dr. Menge said, that we need to really decide that our mothers and our newborns need to be saved. Because most of those causes are preventable. And we can all merge our resources, come and put our heads together at the county level, at the sub-county, even at the village level, to really say, how do we save our mothers and newborns?
You see, here we're talking about maternal and newborn health. And we want to move away from talking about the death aspect, because yes, we agree it happens, but we must move beyond that and start discussing how they are living beyond the challenges that we do have. This conversation has to continue, and it will continue. And next week as well, we'll continue with this very same conversation, because our mothers, our newborns must be alive. I'm Dennis Aseto, and asante sana to our doctors, many would say doctari, that is Dr. Charles Otuori, as well as Dr. Abdallah Bajaber, and we have Dr. Charles Otuori and James Amenge. Conversation continues next week. I'm Dennis Aseto. This is Health and Wellness.